Hello, my name's Christopher, and I've been a nurse at Elmhurst Hospital for the past 7 years, 5 of which have been spent in the emergency room. I want to talk to you all today about issues in our emergency room, overcrowding, and timeliness. This is my proposal on increasing emergency department throughput through workflow improvements. Some background on the issue. Elmhurst Hospital Emergency Department has been listed as a poor performer in many measures to timeliness. According to the New York State Department of Health, the national average is 256 minutes for time from emergency room arrival to departure for admitted patients. Elmhurst is in the top 5 for the poorest performers at 705 minutes. Additionally, Elmhurst Hospital nearly doubles the national average of 135 minutes at 256 minutes for the average time spent in the emergency department before being sent home. This is what we currently do. In triage, the patient is registered. Nurses ask questions and perform assessments, and the patient is moved afterwards out of our internal triage to the main part of the emergency room where they await for a provider. Some cons to this are, after a patient is triaged, they're awaiting for doctor's orders, and all they do is either sit in the waiting room or lie on a stretcher. And due to these long wait times, some walk out. The admission process goes as this. Once the bed is available, the emergency room nurse calls the floor nurse. The floor nurse either takes report, sometimes the phone continues to ring with no answer, or the floor nurse does answer, but states they're not able to take report at this time and to call back. If, when we're able to give report, we then place the patient in system for transport, and then this cycle repeats multiple times throughout the night. Some cons to our current admission process include that it requires multiple phone calls, which result in delays, and when we call the nurses, we have to read from the patient's chart with no format available. This is a list of start to finish in the emergency room. First, the patient arrives and is registered, then triaged. Doctors order tests. Tests are performed by the nurse or the radiologist, and we have a disposition or go to further testing. It's at this point between triage and waiting for a provider that I want to target. This is our door to diagnostic evaluation by the doctor metric. The national average is 19 minutes. Elmhurst is at 78 minutes. Solution. I have 2 different angles of attack. First, I want to place a physician in triage to streamline the emergency department's workflow. Benefits to this include having orders placed immediately for nurses to perform. Patients do not fall through the cracks, minimizing the risk of an improper triage. And lastly, we no longer have to search for doctors to present our EKGs and get orders for medication sedation of emotionally disturbed persons. Our second angle of attack is to use an electronic S-bar and utilize the charge nurse to streamline admission processes. What has changed? Now that the charge nurse is going to be in charge of admissions, after they see that the patient has an available bed, they review the charge nurse reviews the electronic S-bar and phones the charge nurse of the floor that they will be sending the patient up. No report will be needed as all the information is in the electronic S-bar. The floor charge nurse reviews said electronic S-bar, and if they have any questions, they call back. If not, The patient is placed in the system to go upstairs, and they leave the emergency room. This is the team for targeting triage. We will need the director of emergency medicine, the clinical director for doctors, and the director of nurses, the nursing educator, supervisor, and charge nurse. This team also overlaps with those for targeting the admission process. We will need the chief nursing officer, the director of the emergency department for nursing, and director of nursing for med-surg. We also need educators, supervisors, and charge nurse, and importantly, an information technologist who will show nurses how to use the electronic S-bar already present in our EPIC electronic medical record. Conclusion. Who benefits? Everybody. Patients have less waiting time in between triage and provider, and they have less time spent transitioning to the admitting floor if they are admitted. Nurses benefit by having to spend less time on the phone and receive or give report, and have to no more waiting for orders and less angry patients, hopefully, now that orders are present in the electronic medical record for them to perform. And lastly, the hospital. When there's more promptness, there's a change in perception of emergency department's timeliness, and because of a physician in triage, they can capture lost revenue of patients who leave without being seen. Thank you for hearing out my plan.